We're live.
Well, ladies and gentlemen, can I welcome you to the launch of our international report on patient safety. My name's Alan Donnelly. I'm the convener for the G20 Health and Development Partnership. I'm so pleased to welcome over 700 guests from around the world who this week, which is of course Global Patient Safety Awareness Week, are concerned about taking steps to reduce harm to patients and also reduce harm to healthcare workers. And having said that, I'd also like to welcome the many healthcare workers and professionals who have joined us for this. And I'd like to say to you in particular, on behalf of the G20 Health and Development Partnership and to your colleagues, that we really do thank you for the dedication, your professionalism, and the enormous burden in terms of your own occupational health and safety you've had to carry, particularly in the last 12 months with the pandemic COVID-19. But we know that these burdens exist throughout your working career, and it's one of the reasons why we wanted this included in the report. So we launched the report today, and we've described it as patient safety, the overlooked pandemic, and how to transform patient safety and save healthcare systems. And I think it's very clear that this problem has been exacerbated during the course of the last year. There's never been a more important time to discuss the topic of patient safety. COVID-19 has transformed our world and demonstrated how rapidly a new virus can limit our horizons, from international travel down to the most mundane visit to the shops, whilst putting the health and economic opportunities of many billions of people at risk. However, whilst the lockdowns have delivered scenarios not witnessed since the Spanish flu epidemic after World War I, other pressing health crises continue to impact our daily lives. And it's here, with the silent pandemic affecting patient safety, where this vital report will focus its attention. I have to tell you that the G20 Health and Development Partnership is output driven. And therefore, when we come on to talk about the recommendations, these are concrete, and we will pursue these with partners around the world to make sure that we make a significant difference in the coming months and the coming year ahead. Incredibly, according to the World Health Organization, unsafe care results in over 3 million deaths each year worldwide, despite advances in technology and learned best practice, expensive healthcare systems, and years of training undertaken by health workers who display a passionate vocation to heal and not harm. And in patient safety, like so many other areas, we live in an unequal world, because as the Commonwealth reports, the risks of healthcare associated with infections in low and middle income countries is 20 times higher than in high income countries. Now, mistakes in clinical care, as in every walk of life, do occur. And yet we can still do much to prevent harm and promote better outcomes for patients. And that is where this report, The Overlooked Pandemic, which we launched today, takes an in-depth and international examination of best practice and thought leadership. And that's why there's such a diverse range of people who've contributed to the report. Its lessons show we must learn from best practice by sharing international experience from experts with decades of experience. The report is split into 13 chapters across 4 sections that focus on, first of all, principles of patient safety. Secondly, practical examples of delivering patient safety in the national health care context. Thirdly, politics of patient safety and the global stage. And fourth, Patient Safety 3.0, the future vision for this vital field of public policy. We're not doing this alone, but very much with the support of the international community, as we witness the focus on patient safety by the G20 under Italy's excellent presidency in 2021, following the leadership by the Kingdom of Saudi Arabia last year, who actually put patient safety on the agenda of the G20 for the first time. And we are delighted that representatives from Saudi Arabia and Italy are with us today. The G20 has rightly joined together with civil society organizations around the world to address the challenges facing patient and healthcare worker safety, and to discuss how the leadership of policymakers, existing digital health solutions, and best practice across care settings can help move us towards a world free of preventable patient and health worker harm. And that's why we are so pleased to include chapters in the report from leaders at the World Health Organization, the OECD, the ILO, and the IAEA, as well as other leading representatives from NGOs, health worker associations, and political leaders. So we're proud to launch the report today with your support, and thank you for joining us. You can find the link to the report in the chat option on the screen, and you can download it from the link. We look forward to you reading the report, and more importantly, offering your feedback and suggestions on how we can make the recommendations a reality, which is the aim of the work we're trying to do at the present time. The format of today will first be some keynote speeches, and then we'll move into a panel discussion. We hope that you'll submit your questions via the Q&A chat option on the right-hand side of the screen, as we're looking to put these questions to our panel. And we want as many of you as possible to have the chance to raise questions or make brief comments. And please also tweet about the event by using the hashtags, which you can find in the chat box, which is hashtag Zero Harm or hashtag PSAW2021. Now I'm pleased to introduce the first of our keynote speakers, Dr. Tedros. I can't hear him, teacher.
One second.
Dear colleagues and friends, access to care is central to universal health coverage. But it's not care if it's not safe. Unfortunately, the delivery of safe and quality care is now a bigger barrier to good health in most countries than the lack of coverage. Avoidable harm in healthcare is an overlooked pandemic. And half the global burden of patient harm originates in primary and ambulatory care, which as many as 4 out of 10 patients facing safety lapses. Up to 80% of harm in primary care settings can be prevented with the proper safeguards. While patient safety impacts every health system, unsafe care disproportionately impacts low and middle-income countries. 134 million adverse events occur in hospitals in these countries every year, contributing to 2.6 million deaths. As a result, communities can lose trust in the health system and stop seeking care. In response, WHO has developed the Global Patient Safety Action Plan for 2021 to 2030, which will be considered at the World Health Assembly this May. The action plan is designed to support countries and communities to work across health systems and with health and clinical programs to eliminate harm in healthcare and transform patient safety. WHO remains committed to working with all countries and partners to give the people we serve the care they deserve. Safe care. I thank you.
Well, Dr. Tedros, of course, has shown incredible leadership over the past year, particularly. But of course, he and his team are not only concerned about the global pandemic, although that's been their preeminent concern, but as you've heard, his team have been looking at a range of other things. And I know while she isn't speaking today, we have Dr. Neelam, who's joined us, who's head of patient safety within the World Health Organization. And Neelam, we thank you and the team at the WHO for the work you do. Now, as I mentioned, the leadership of the Kingdom of Saudi Arabia placed patient safety on the agenda of the G20 for the very first time during its presidency in 2020. And in my view, set the standard that we should be looking to ensure international engagement in the future. Therefore, I'd like to hand over to Dr. Abdullah Al-Hawasi, who is a global ambassador for the G20 Health and Development Partnership. And he also sits as an executive member of the Global Sepsis Alliance, who are recently members of the partnership, to introduce our next speaker. So Dr. Abdullah, over to you.
Thank you very much, Alan, and thank you everyone for joining us today for a very important day on the Patient Safety Awareness Week to introduce this very important report. So it gives me a pleasure and honor to introduce the next keynote speaker, His Royal Highness Prince Khalid bin Sultan bin Abdulaziz Al Saud, the Saudi ambassador to the United Kingdom. Prince Khalid, the floor is yours.
Thank you, Dr. Abdullah, and thank you, Alan, for convening this event and giving me the chance to speak to all our guests today. I'd also like to thank Dr. Tedros for his excellent remarks and the pledge to improve the safety of patients and healthcare workers now and in the future. And a special thanks to all the contributors for having compiled this exceptional report and for hosting us all here today. In 2016, Crown Prince Mohammed bin Salman launched the Kingdom's Vision 2030 program. At the center of this program is the health and welfare of our population. And if we've learned anything from the current pandemic, it's that no country can remain healthy in isolation. Therefore, promoting global health security is very much part of our vision moving forward. The WHO and the global health community have done a tremendous job in trying to bring an end to this pandemic. However, without the tireless efforts of frontline health professionals and healthcare workers from around the world, some of us might not be here today. For those health professionals who have joined us, I'd like to convey my special thanks. You've been on the front line of the war against COVID-19, and sadly, many of your colleagues have paid with their lives. For over 12 months, we've all been discussing what lessons we have learned from this pandemic and how to improve. But we've also learned that there's no silver bullet. To solve this challenge, we can't be alone, and we need to work in partnership and across sectors if we want to prevent future pandemics. Today, we're discussing the importance of patients and healthcare workers' safety through the lens of civil society organizations, private-public partnerships, multilateral organizations, politicians, and clinicians from across the health and non-health sector. The report Overlooked Pandemic comes at a critical time, and WHO statistics speak for themselves. Over 1 in 10 patients suffer harm while receiving hospital care. This statistic has surely increased throughout the current pandemic and will further harm societies and degrade economic performance and recovery. Indeed, the safety of patients and healthcare workers impacts the safety of our societies and economies now and for years to come. Kingdom of Saudi Arabia has taken up the mantle of patient safety nationally and globally. Since 2019, we had the honor of hosting the 4th Global Ministerial Summit in Jeddah on patient safety, with attendance of over 1,500 global health experts from around the world. Among the summit's conclusions was that if we're to deliver universal health coverage by 2030, we need better collaboration to improve and promote patient safety globally. Together with the creation of the first National Patient Safety Center that drives new policies to put the patient at the heart of the healthcare system, Saudi Arabia has also placed patient safety as a central tenet of its G20 presidency in 2020. 2 years after the Jeddah Global Ministerial Meeting, and in the midst of this pandemic, it's become even more clear that both patient safety and healthcare workers' safety are fundamental to building resilient healthcare systems and a sustainable world economy. The recommendations in this report are practical and achievable if we work together, and I'll be communicating recommendations to my government in Riyadh. The contributions by the distinguished authors to this report demonstrate why we must carry forward the importance of promoting health and well-being, the health and well-being of our patients and healthcare workers to the current G20 and G7 presidencies and beyond. The Kingdom of Saudi Arabia is committed to continue to play a leadership role in improving patient safety and global health security in this challenging period for all citizens around the world. It's a pleasure to be here with you today, albeit virtually, and I look forward to working with you going forward. Thank you very much.
Prince Khaled, thank you very much for your well-chosen and important words. And, you know, often when a G20 presidency ends, the country simply moves on and allows the next presidency to continue with its own agenda. But I think what's really significant is the commitment that you've outlined today, where Saudi Arabia is continuing its commitment to patient safety, and the fact that Italy has taken forward what you achieved during last year. And I really do hope that, and I actually believe that under the Vision 2030 strategy, that Saudi Arabia will continue to be a global leader when it comes to patient and healthcare worker safety. So thank you very much for that. I'm now pleased to introduce Jeff Surges, who is the CEO of RLDatix, a British business created, I think, over 30 years ago to help provide the tools to improve patient safety initially in British hospitals, but now with an incredible global footprint. And RLDatix have also very kindly sponsored this report to make sure that we can get as much support from around the world as we possibly can for the ideas and recommendations in it. So Jeff, thank you for the support of you and your staff and for the work that you do to improve patient safety around the world. And you have the floor.
Well, thank you, Alan. Your Royal Highness, distinguished guests, let me say how pleased I am that RLDatix is to have sponsored this important report and to join the launch today to support and promote the author's findings. In particular, Your Royal Highness, let me say that it is an honor to follow you today. It is inspiring to be reminded about the strides taken on patient safety under the auspices of the Kingdom of Saudi Arabia's leadership of the G20 last year. From the Global Ministerial Summit to the National Patient Safety Center, the Jeddah Global Ministerial Meetings, your country's prioritization of this vital issue and the wider global health security has changed the debate and set the future agenda. Our partnership with the Kingdom of Saudi Arabia is hugely important for RLDatix. There is no substitute to having local representation, and RLDatix is proud to have our company based firmly in Riyadh since 2009, where our office ranks alongside our other international headquarters in Chicago, London, Toronto, and Melbourne. After all, the scale of the challenge could not be more stark. Before the start of the pandemic, 1 in 10 patients were harmed while receiving hospital care, according to the WHO. Since then, further challenges have emerged that contribute to patient and health worker harm, including increased infection rates, overcrowded facilities, and limited access to PPE. On a macroeconomic scale, the pandemic has left G20 economies with a deficit of 12 trillion US dollars, exceeding the 2008 economic crisis entirely. That is why, to build back our economy stronger and better than before, we need to identify risks and prevent harm, care for the mental and physical well-being of global health workers, and ensure that patient safety is at the forefront of the global healthcare agenda. As I write in the report, industries such as aviation and nuclear energy already serve as a good model. In aviation, for example, an individual has a 1 in 1 million chance of being harmed while traveling on an airplane. In contrast, the patient experiencing harm in a health system has a 1 in 300 chance of having an issue. These numbers alone demonstrate a clear need for coordinated action and to address safety in healthcare while providing hope for what is possible if we commit ourselves to this change. We require fast, coordinated, effective solutions to address patient and health worker safety that includes digital health technology. What's more, transforming institutional and global care delivery to achieve what we call zero harm demands systemic and cultural change across healthcare organizations globally. At RLDatix, we are committed to building digital health and patient safety tools to help achieve the United Nations Sustainable Development Target by the 2030 goal. For more than 3 decades, we have been a trusted, ethical patient safety and risk management software and services provider for organizations across G20 countries, including the Kingdom of Saudi Arabia, the United States, Australia, Denmark, Canada, and the United Kingdom. RLDatix fully supports the decisions of governments of Saudi Arabia in 2020 and now Italy in 2021 to promote patient safety as central tenets of their G20 agenda. Indeed, we also acknowledge the leadership of Dr. Tedros and the World Health Organization, as we have heard today, in addition to initiatives like the WHO's Charter on Patient Safety. Collectively, we are uniting around a shared vision for patient safety. This report demonstrates how the safety of patients and health workers is inexorably linked to all global health challenges, including infectious and non-communicable diseases. Without acknowledging safety challenges that patients and health workers face, reopening our societies, growing our economies, and improving the resilience of healthcare systems will be more challenging than ever before. We just simply cannot afford to let this happen. The time to change is now. RLDatix is a proud sponsor of this vital report. I look forward to the debate today and the conversation, and pledge our company's support for the campaigning of members of the global health community present here as we work together to transform patient and healthcare worker safety. Thank you, Alan.
Jeff, thank you so much. And I do think the work that you're doing in Saudi Arabia is very, very interesting, because as Saudi Arabia changes its approach to how healthcare is managed, the delivery of patient safety, of course, must be ensured. And I know that RLDatix is playing its part there, as it has done for many years with hospitals in my own country of the United Kingdom. So thank you so much for that. I also want to just mention that we've got the G20, of course, which is got health. It's got patient safety and healthcare worker safety on the agenda. But I don't want to miss out the G7 leadership that is being shown by the British government. The Prime Minister has made a very strong point of having global health security and health system resilience on the agenda of the G7, and they've already had rounds of meetings with experts, particularly looking at pandemic preparedness and response. And of course, in the document that we're launching today, the former Secretary of State for Health and Social Care, and also he was the former Foreign Secretary, Jeremy Hunt, very kindly has contributed a chapter to this. So we're incredibly grateful to the leadership of both the G20 and the G7 with that. So Jeff, thank you. Thanks so much for joining us. And I want to move now into our panel discussion. And I'd like to just explain to everyone that we undertook this project, as we do within the G20 Health and Development Partnership, to include the very best thinkers and practitioners, but not only people who are clinicians and people who work in health. Because one of the things we've tried to establish, and I think we're doing it now successfully, is to make people understand that if you want to have a healthy economy, you've got to invest in your health system. And you've got to make sure you've got a resilient health system. And it's interesting, during the Saudi presidency, that we saw conclusions from the heads of government meeting where they are now talking about spending on health as investment as opposed just to spending. And so I think we're moving the narrative now on health into a different direction. And that's why the contributors to this report come from a wide selection of leadership in our global community. And I'm really pleased that we're joined today by Annette Kennedy, who is the president of the International Council of Nurses, Dr. Lucia Guidotti, Director General of Health Planning and Quality at the Ministry of Health in Italy, from the Directorate, Dr. Abdullah, who you've met already, who was the former head of the Saudi Patient Safety Center and is now a global ambassador for the G20 partnership, and is an executive committee member of the Global Sepsis Alliance, and Dr. Philippe Duneton, who's the executive director of UNITAID. And UNITAID does an extraordinary job in helping to scale up initiatives around the world, innovative initiatives to tackle some of the most pressing health problems. And they've done extraordinary work recently in therapeutics on COVID-19 and issues related to cervical cancer with women in low and middle income countries. So I'm glad that the panel have been able to join us. And what I want to do is just to, first of all, ask each of the contributors to explain why they put the content they put into their own chapter, and why did they prioritize these things. And I'd like to first of all ask Annette and then Lucia for their thoughts on this. So Annette, what spurred you to have this theme as your chapter?
Thank you, Alan, and good morning, good afternoon, good evening, Your Royal Highness and distinguished guests. I'm delighted to be here today, and I'm delighted to contribute to the very important report. For me, it's very simple. Keeping health workers safe, and particularly nurses, is keeping patients safe. It's as simple as that. It's two sides of the same coin. Health workers, and particularly nurses, are in the front line. Nurses make up 60% of the health workforce. They're the backbone of the service. We've seen that now with COVID-19. Without nurses, you couldn't curb COVID-19. Neither will we roll out mass vaccination. That's obvious. But what's more important is we went into this pandemic unprepared, under-resourced, understaffed. We were 6 million nurses short. 80% of that 6 million are in the lower and middle income countries. Added to that, in the next decade, we will see a shortage of 4.7 million nurses who are due to retire. That's 10.7 million nurses we're talking about. Over 60% of our national nurse associations from 135 countries have said, because of the conditions and because of what the nurses faced, both physically, mentally, and the trauma that they experienced during COVID-19, quite a high proportion of nurses plan to leave the profession early. We could be looking at 50% reduction of the current health workforce. That will mean that we won't have a health workforce. That will mean that there will be no healthcare, because you cannot operate with 50% loss of nurses. The evidence supports, quite over a long period of time in many countries, that keeping health workers in positive practice environment, remunerating them, having appropriate skill mix, having staff to patient ratios, having competent nurses will reduce patient mortality, patient morbidity, adverse events. It will cut down on the length of stay, and it will reduce patients coming back into hospital. The evidence is very strong and it's there, but we haven't done that. We haven't invested in nursing. We haven't invested in education. Why? When we see that, you know, keeping patients safe and patients, the quality of care up and keeping them healthy keeps a healthy economy. It's simple. It makes sense. Added to that, what really concerns us is that 10% of the healthcare workers contracted the virus. When you talk about 110 million contracting the virus, you can talk about millions contracting the virus. They will have post-COVID symptoms, that's for sure. In 56 countries, 3 million nurses have died. We know that's an underestimate. We couldn't afford to lose one nurse, let alone 3,000. So I am extremely concerned about what will happen. We have seen that in New York or in other countries, that where you haven't had good resources, where you haven't had adequate staff or equipment, patients lied waiting for services. Whereas in well-equipped hospitals, like private facilities in the same city, patients were well looked after and the outcome was much better. That's inequity, not just across countries, but within countries. It's not acceptable. And we talk about patient safety. We can't have patient safety unless you look after the people that look after the patients. I am extremely concerned about all of this. I'm extremely concerned because nurses haven't been involved in the actual strategy for COVID. They haven't been central to the decision-making, always the implementers. We haven't been involved in the actions, the task forces. We have been implementing, but yet we're the closest to the patients in hospital, in healthcare facilities, in older person care and in communities. So you ask me why I am interested. Of course I'm interested in patient safety. Of course I'm interested in keeping nurses safe. Because without doing that, I can guarantee you the pandemic that we now face is nothing to what the pandemic we will see in the future. Thank you.
Annette, thank you very much. And I just want to pick up that last point you made and just say that we'd like to discuss it offline with you about the participation of frontline healthcare workers in the review of pandemic preparedness and response. It's really important, I think, that the voice of your members within the International Council of Nurses is heard, because they will be able to express very strong and practical thoughts about where the gaps were. This can not only be done, I think, by national chief medical officers and so forth. It does need people on the front line to be listened to at this time. So in the partnership, we'd very much like to talk to you offline about that and incorporate this into some of our recommendations. So thank you. I'd like to move on now to Dr. Lucia Guidotti, who is from the Directorate General of Health Planning, Quality, Clinical Risk and Hospital Planning at the Ministry of Health in Italy. And of course, Lucia, as she was telling me early, effectively is the person who deals directly with the incidence of if there's a problem with any issues of patient safety that comes across her desk. So Lucia, your the thoughts on I know it was Dr. Rucco who wrote the chapter, but I know you work closely with him. So what's your thoughts based on what's in that chapter from the Italian Health Ministry?
Okay, thank you, Alan. Thank you, all of you. I would like to thank people that make this meeting available for all the people. And I would like to thank WHO and particularly to Dr. Tedros and also Nilan Dhingra. Yes, as you said, Alan, I'm working on patient safety from several years, and the Italian Ministry of Health, in collaboration with other regional organizations and other entities like Agenas, our agency and national institution for healthcare, ISS, we are working closely in order to give better results, because we know that working together can give us the possibility to obtain better results. Which are the activities that the Italian Ministry of Health is performing in these recent years? Because you know that patient safety is starting in the beginning of this millennium. In Italy, we have an activity that is based on 4 different pillars. The first one is the collection of information on sentinel events. And this is web-based. It's necessary to have information on what happened at a local level. And in order to have a better results, we involve the role of risk manager. That it's very important, is a crucial role inside the hospital, is defined by a law in 2012. We introduced this role inside the hospital, and it carries out about all the things related to safety of patients. When an adverse event occurs, we have to check in 3 times at different level, at local level, hospital level, at regional level, and the final check is at ministerial level. After this, when we are sure that it was a sentinel event, the information are collected together in a database. Up to now, we have about 10,000 sentinel events. It's not a very huge number, but it's enough to understand and to have more information on what happened. The system is web-based, then it's easier for the people to have access, and also it respects the minimum information model given by the WHO. And we have 16 different categories of sentinel events. I have to say that in 2017, we had a new law introducing the possibility for Agenas, our agency, to collect information on near misses and other adverse events, not serious as Sentinel-1. We have the second activity, that is site visits performed by unit of crisis, that is a task force of health professional from the Ministry of Health, but also from the agency. And it involves also nurses when it's necessary, because it's necessary to work together to have better results. After a site visit, a report is made, and inside the report are defined some action to put in practice in order to avoid similar events. And the third activity is ministerial guidelines, ministerial recommendations. We have 19 different recommendations. The topic that it's more frequent populated is the use of drugs, since the use of medicines has some aspects that are quite critical. We have these recommendations are published on our website, then are quite available for all the people working at the front line, and they are simple instruments and tools to put in practice in order to avoid similar events. And the last pillars, last activity, it's easy to say, but believe me, it's a very huge activity, a concrete, a complete activity to do it, to carry out. And the last one is monitoring of the activities performed at regional level, because we have a system strongly regionalized, and then it is necessary to monitor what is going on at local level. And this is why we are doing this in order to check what is going on, and if the quality of the system is adequate to the necessity of the citizens there. If I have to speak about the pandemic, we see that our system, even though has some flexibility and had the capacity to have a resilient versus what happened, versus the crisis of pandemic. We know that we have a problem, as Annette Kennedy said, related to the number of health professionals, because we know that in recent years, the number of health professionals is reducing. Then it's necessary to reinforce our system, our healthcare, the number of healthcare workers, especially the nurses that are very, very involved in this process. And also other aspects that seems to be critical for our system is to reinforce the network at local level, what is district services and the network with general practitioners. Then from my side, I can say that I suppose I finished my time.
Thank you, Lucia.
And then if you have some question, I can be available to answer and to reply. Thank you so much.
Lucia, thank you so much. We know that Italy was the first country in Europe really to be hit badly by COVID-19, and obviously all countries have realized that they have to make improvements to their health system resilience in their response mechanisms. But that's really, really interesting. And also the fact that you've raised the issue of health in the digital age. And I do think that's going to have to play a much more important part in the future. Can I move over now to my dear friend, Dr. Abdellela? You have the floor, Abdellela.
Thank you, Alan. So I wrote the chapter about zero harm, and before I answer, I want to share with you a story, which is a public record story that I mentioned last year in the G20 Health Working Group. So in 2007, the known actor Dennis Quaid and his wife went through a scare when their twin babies actually received the wrong dose of heparin. And for non-healthcare people, heparin is a blood thinner. But the problem is the wrong dose was 1,000 times the dose that they should have been given. And not only once, but twice. That, fortunately, they managed to actually survive that, big mistake. And this happened in a hospital like Cedars-Sinai. So if someone like Dennis Quaid in Cedars-Sinai could be, facing such a major mistake, medical errors and mistakes do not discriminate, with geography, ethnicity, religion, what have you. So these are all kind of issues of healthcare systems problems. Zero harm comes from the very known principle in healthcare, which is do no harm. So we as clinicians, I'm still a practicing surgeon, if we cannot help the patient, at least as clinicians, we should not harm them. And Dr. Tedros spoke about more than 3 million people and the 2.6 million deaths in low middle income countries, 134 million adverse events. I think we should resist to talk about these numbers in a dehumanized way. And what I mean by that, I think we have to think about those numbers as individuals, with family members. I have a 17-year-old son and a 10-year-old daughter. And if I think it's unacceptable for them to be harmed by through healthcare, I think it is hypocritical for me to accept that for any of my patients that I'm looking after. So the concept of zero harm is zero harm, not just for patients, but zero harm also for healthcare workers and zero harm for the healthcare facility. And truly, and I just to follow up on the discussion from ICN, I spoke in ICN a couple of years ago where we talked about the two safeties, which are the safety of health workers and the safety of patients are two sides of the same coin. So these are not kind of a zero-sum game, but they are complementary. And I mentioned a quote in my chapter, which is, we're still looking at this as a big elephant, but then how do you eat an elephant? One bite at a time. So rather than thinking about this undoable, destination, we can have zero harm per patients per shift. So if I'm a nurse and I have a patients looking after, I can work with my patients and their families and the entire team to have zero harm within that shift, and we can celebrate that zero harm. And then slowly and surely we can build that up, but and we can reach the zero harm goal. So I hope that the audience and people listening to us will read this chapter and will read the whole publication. And as you mentioned, we're interested in outputs and outcomes and how can we really transform the safety in healthcare. Thank you.
Abdullah, thank you. And also thank you for your dedication on this issue. I mean, one of the things that's really interesting is the recommendation calling for the creation of the global patient safety and healthcare worker fund to help create toolkits so that we can have best practice around the world, and we can help low and middle income countries to have best practice too. And it's something that we're very proud to be working with you on. So thank you for that. I want to move on to Philippe Duneton, who's actually a scientist. He's the head of UnitAid. And UnitAid is an extraordinary organization that has supported so many initiatives around the world to help tackle issues, acute and chronic issues related to healthcare. So Philippe, thanks for joining us today. And why did you want to make the comments that you made in your chapter?
Thank you, Alan, and thank you and Your Royal Highness and all the colleagues around the table. I have to say that I will start to say that it's rare to be so aligned all together on one topic. And I'm saying that because, of course, I've been writing the chapter with Marisol Touraine, the chair of the board of UnitAid, but also a former minister from France, and she has been also exposed to that kind of challenges. But also as a medical practitioner in my work in the hospital and certain program before UnitAid, I've been exposed and working on that kind of issue. And it's close to my heart because it's close to the medical practice, I have to say, and safety of patients is quite key. I just want to highlight why I think it has been said before me. Dr. Tedros made the clear link between quality and safety. And I think Arnett had made the close link between the safety of the health workers and the safety of the patient. And I recognize myself fully in the words of Dr. Abdullah on no harm, do not harm, so zero harm. So basically, I just want to pick an example as UNITED. I can pick a lot of examples, and you will see in the chapter. But I want to make the point that UNITED is focused on innovation. So, of course, you need resources, you need financial, but also people and health workers, and the time for the health worker to take care properly with quality. But you need also tools, adequate tools. And innovation for us as UNITED is how to simplify, how to accelerate, but how to transform access to health system, including how to simplify the way that the health workers are working. So let me take an example. We are investing a lot in malaria, but also we are acting also in the ACTA for against COVID-19. So I could pick a lot of examples. But what we have done with WHO under the recommendation of WHO is to push the switch from the use of quinine among children and versus artesunate injectable. To make it simple, quinine is it's a very good drug to kill the malaria. But unfortunately, the toxic level is close to the therapeutic level. So there is risk for adults, but in particular for infants. And I think Dr. Abdullah made the point, an example with heparin, but it's dramatic when you push too much quinine. You don't have the same risk with injectable artesunate. And in fact, WHO shows that 20% of reduction of mortality using IV artesunate versus quinine IV. So we push that. It's ongoing. In the next 3 years, we are expecting with the scale up in countries that more than 150,000 deaths that can be averted using artesunate injectable. But also, the point I want to make is better for the children, it's better for the adults with malaria, but it's also best for the health workers, because the way you have to monitor the babies or the children is totally different. Of course, if you have something that is quite a challenge in terms of safety, where of course with artesunate it's more safe, so you have less attention to make. And that's the kind of feedback when I'm going to the hospital in the field and talking with the doctors and the nurses, and they recognize that, yes, it has been a dramatic change. So as an example, again, we have many examples on that. There is first a need to recognize that quality is linked with safety. More simplicity in terms of care will free up time for the healthcare and will reduce the risk. So again, we are fully engaged into that. It's not my personal conviction, which is, I have to say that it's very clear, but it's also the organization. So we are fully aligned with that. I think there are many ways to see the public health challenges. This is for sure one, but there are different ways to help and to make sure that we are shooting in the right direction. Thank you, and over to you, Alan.
Thanks very much, Philippe. And as I say, that we are very, very. It's very impressive to see the work that that UNITED does around the world with your own partners. One of the things that one of the questions that came in, and I want to pose this question to you and to Annette, because it's a very. I mean, it's a fundamental question, and it comes. It's been raised by quite a number of people, but the person who posed it first is Dr. Umesh Prabhu, who's the medical director of 2 acute trusts in the National Health Service. His question is: different countries have different cultures and different levels of healthcare funding. How can the same patient safety principles be applied for different countries? So I'll go to Annette first, and then Philippe, if you'd like to comment on that, because this is the whole issue of, can we have common standards and equitable treatment? So Annette, you with your practical experience.
Yes, I think that it's a difficult question because equity across the world, if you're talking about equity in resources, you will probably never find that, or in the exact number of nurses stroke doctors to patients. However, I think that what you should be looking at is different models of care. We have seen currently with COVID-19 that our models of care were not appropriate. We are not investing in public health. We're not investing in primary care. We're not investing in, as I think Philip has said, different applications that would assist in patient care. There's all sorts of technology. If anything, we have seen this year that technology has a role to play, and particularly has a role to play in patient care. I have seen across the world, nurses trying to, I suppose, set up different applications, set up different initiatives that will work in different countries. So they're bringing care to the patients as opposed to the patients coming from the care. And I'll just give you examples. A number of nurses in, say, Latin America and Africa, because patients can't access care, they have gone out on horseback, they have gone out on bicycles, they have gone out with vans, trying to bring care to the patients so that they can assess the patients early, that they can intervene early, they can give education early, before they get to the stage that they need treatment in hospital. And I think that makes a huge difference in relation to the cost of care, in relation to the actual country that you're in. So we have to look at the country you're in and seeing what's the best for them. But I think a lot of the high income countries can learn from the lower and middle income countries, because I don't think that we have gone with the right model of care. So yes, technology is first. Second is what model of care is best in country, and how can we support the nurses, even in isolated areas, with neat applications to help them actually deliver care. Because if you're isolated, you can get information through technology. It's easier now than it ever was. So we have to look at different ways of managing care. And I think that we can do that much, much better. We haven't been.
Thanks, Annette. 1 minute, Philippe, your thoughts on this? No, Annette, it was, honestly, it's fantastic to hear, because it's practical. I mean, this is like, as we would say where I come from in the northeast of England, it's from the coal face, so it's really important. Philippe, your thoughts quickly, 1 minute on this.
Well, just to say that I support fully what Arnett was saying. Maybe just a thing that, if you look at the expenditure in health, first, we need to have more resource into that, and human resource, of course, and technology. But if you look at the US, I think the cost of access to care is 20% of administration, maybe around 12 or a little bit more in Europe. And I think that we can do the same for, let's say, 5% in a lot of LMICs, but with the condition that we have a technology move to organize things, including the quality. And I think it's something that, for example, if you are focusing on primary health care, there is a different type of meaning in different type of country. But if we can work the country to say, okay, what are the goals, and what can tool, training, resource you need to put to make this happen is absolutely key. I will stop here.
Philippe, thank you. I want to just bring in Richard Amalvi, who's the Chief Executive of the Brazzaville Foundation, because one of the issues that we've come across when we've been speaking to people, for example, in some of the African countries who are partners of ours, and that's the issue of counterfeit medicines and the impact that has on patient care. I just wonder, Richard, if you could just briefly give us some thoughts on that. You're on mute, Richard.
Thank you, Alan, for giving me the floor. Your Royal Highness, distinguished guest. Yeah, hundreds of thousands of Africans are estimated to die each year from falsified medicines. At the Brazzaville Foundation, following Dr. Tedros' expectations, our job is to ensure patient safety by providing a better access to quality medicines. We work with 6 African governments through the so-called Lomé Initiative. It's the Republic of Congo, Ghana, Niger, Senegal, Togo, and Uganda. The pandemic increases the urgency of action against traffickers who feed crime and terrorism. Our pledge today is to expand the partnership we created to secure the pharmaceutical supply chain integrity in the countries we work with. So our request to the G20 is to take this issue head on to support countries that consider patient safety a priority. More than a public health issue, it's also a matter of security and rule of law. So my question to Mrs. Guidotti is about the agenda of the next G20 in Rome. Is the fight against falsified medicine a subject on which the Italian presidency is working or could work?
Thank you so much, Richard. Before I bring Lucia back, I'd also like to invite Professor Conrad Reinhardt, who's a member of the executive committee, I think helped to found the Global Sepsis Alliance. And I just wonder, Conrad, if you'd like to just put your question or make some comments.
Yeah, indeed, it's a pleasure that I could contribute with my colleague, Dr. Alawasi and Imran Malik from the MD Anderson, who are members of the board of the Global Sepsis Alliance, and to speak about sepsis and to explain that sepsis is the #1 killer in the world, and to explain that the reasons, sepsis is the reason why pandemics are so dangerous. You should know, everybody should know, and this is not known, that non-COVID sepsis kills annually 11 million people. We know that COVID-19 added now 2.6 million, and every other pandemic is dangerous, as I mentioned, due to sepsis. And when we founded the Global Sepsis Alliance in 2010, the word sepsis was not found in the A to Z list of the CDC. It was not in the Global Burden of Disease report. It was not on the website of the WHO, except for maternal and neonatal sepsis. And the number that I mentioned to you, that we have 49 million cases annually, only in last year's Global Burden of Disease report was first made public. And that I am so glad that Abdullela and others have addressed it in the context of the ministerial patient safety summits. And I was so glad that Germany in 2017 helped to have a resolution on sepsis by the WHO, which asks member states and urges member states to integrate sepsis in the national healthcare system, because it's the #1 cause of preventable death and disability. It was already mentioned by Annette Kennedy on the long-term sequelae of COVID-19. The same is true, but was not in the mind for sepsis of other causes. And that's why we would be so happy, and that's why we joined the G20 Health Development Partnership, to get really sepsis on the agenda of the next G20 meeting, on the next G7 meeting, which is under the auspices of Germany, who brought AMR and nosocomial infections on the agenda several years ago. And also for Indonesia, we would like to have this on the agenda, because what we learned in this pandemic was the important role of policy. Without the right decisions by the policymakers, you could have the best healthcare systems in the world, but it's crucial. And if we want to make a difference, we need this close cooperation between science, between advocacy groups, and the policymakers. And this is that's why it's such an important topic for G20 and G70. So
thank you, Conrad. Conrad, we'll certainly be speaking to the Indonesian government over the coming weeks to see if they would be prepared to put sepsis, to have sepsis addressed on the agenda for next year. And I believe that Germany have the G7 presidency, and it's another hidden pandemic. So we're looking forward to working with you on that. Now, we had a question from the German Ministry of Health, and I'm going to read it out to you. It's from Ingo Hartel. The involvement of first-hand, i.e. medical practitioners' experiences in the planning of the response to the pandemic is crucial, which is the point, of course, Annette made. It should best be used in a structured way. Patient safety provides good tools, such as CIRS and learning systems that could make this knowledge accessible for policymakers, but this resource has hardly been used to visible effects during the ongoing pandemic. What might be the reason, and how could that be improved? So that's the point from Ingo. And then the final thing I'd like everyone to, I'd like some of you to reflect on Ingo's question, but also my final question to you all, also, perhaps I'll give you a couple of minutes each on this, is, I mean, what are the lessons learned for us in the field of patient and healthcare worker safety? You know, and how can we be more proactive? Instead of just talking about these things, you know, what can we do in tangible terms to get proper results? So I'm going to start with Lucia for 2 minutes, because there was a direct question to you. And then I'll go to Abdelela, and then Philippe, and I'll finish with Antoinette. So Lucia.
Thank you, Alan. It's not easy to answer to this question, because I know there are some critical aspects. First of all, can you hear me and see me?
Yeah.
Okay, thanks. Because there are some aspects that are crucial. First of all, the resources, that is not, they are never enough. Then it's necessary to put more money on hiring people and try to have more workforce. Then it's necessary to decide this at the national level, and also each country for their own activity inside their national health organization. And another aspect is training for people working there, because up to now at university level, we don't have in our courses at the university level specific topic on patient safety. If you want to go in details, if you want to improve your skills on patient safety, you have to search some dedicated courses, but it's up to you if you want to do this. Then it's necessary to organize at university level those kind of courses and practical actions also at hospital level. And other things that in my opinion are important are related to the communication. As complete and transparent, and also involving the citizens, the patient in this process.
Yeah. Lucia, we're going to have to move on, but I think the point of transparency and training and involving the patient is really important. So let's take those 3 points. We'll go to Abdelela next, and then Annette. So Abdelela, 2 minutes. Thanks, Lucia.
Thank you.
So Einstein says we can't solve the problems by the same level of thinking that created them. I think in healthcare, we need to learn from other industries. And I mentioned 3 industries, oil and gas, aviation, and nuclear. Basically, in 2016, I visited Saudi Aramco as just to look at their safety practices with a group of safety experts from the WHO, and we learned a lot. That safety in oil and gas is religion, safety in aviation is religion, safety in nuclear is religion. We're far from actually calling safety religion in healthcare. So I think putting zero harm as a true north for us is a way forward. One quick point about advocacy. If you ask 10 people about the global climate change, I think you're gonna find probably 9 or 10 out of them know about the global climate change. I've done that in my family. I've asked my mother, and I've asked all the way down to my daughter, and they all know about the global climate change. Ask the same 10 about patient safety and health worker safety, and you're gonna be, you're gonna find that big delta of the people that not knowing that. So our job is, how can we translate those big numbers into something that the public would understand, and we can work together to really, towards zero harm.
Thanks, Abdullah. Actually, I'm going to take Philippe next. I'm going to I'm going to let Annette have the last word, because I'm sure she'll want to talk about, again, staffing and training. Philippe, your thoughts on this?
Yeah, I think, again, I agree with my colleagues. I would highlight 2 ways to consider it. I think that patient safety, and again, it's linked with health worker safety, is about risk and risk management. So I think that if you look at the perspective, it's another way to say, like Dr. Abdullah, about the culture or the religion in terms of our industry, and we need to think that way. It's a little bit cold in a way, but it's quite efficient. The second point is to think about impact. In everything we do, we try to be led by impact. So what is the change in terms of access to healthcare? What is the change in terms of quality in reducing mortality and morbidity? And in that case, I think that everything we can do and we are doing for public health should include what is the impact of patient safety. Up to you, Alan.
Philippe, thank you. I know that UNITAID are very big on evaluation of your own programs, and people recognize you as a world leader on your process of evaluation. Annette, I'm going to bring in Sachin Agrawal, who, on behalf of Jeff Surges, just to make a comment on being proactive. And then, as I say, I would like you to have the last word from the panel. So, Sachin, you wanted to make a quick comment.
Sure. Thank you, Alan, and thank you all. I agree with all the colleagues here. I think this idea of moving from reactive to proactive, we can't underscore enough the importance of the availability of data and information to make that, to make those determinations, right? So that we can get ahead of potential patient safety events. And on the topic of sepsis, right? The organizations that are handling sepsis very well have demonstrated that with the availability of data from systems such as the electronic medical record and other sources, combined with the appropriate controls in place, that up to 60 to 70% of sepsis cases can be completely avoided. So there are case studies around the world on that. The second piece around the availability of data that we've really learned through the pandemic is that provider burnout, whether it's nursing burnout or physician burnout, frontline burnout, we used to have this common belief that it was just tied to patient safety events, but that's certainly not the case, right? We now have data that's showing that up to 1 or 2 out of every 5 providers is experiencing burnout not related to direct harm, and we need to have ways to capture this information as well, so that we can provide emotional first aid to those frontline professionals and ensure that the infrastructure of our healthcare system.
Thanks, Sachin. Annette, my daughter-in-law is a mental health nurse, and she has been working, visiting her patients at home throughout the pandemic. At the beginning, by the way, with very inadequate PPE, which we had to purchase for her. But the thing is that what always irritates me is people talk about nurses in a very romantic way about, they have it's all about their... Hello? it's all about their calling and so forth. The fact is that they are professionals and they need proper occupational health and safety. And that's, if that's provided, that's how we start to guarantee that people will want to be and properly paid. And that's how we guarantee that people will come into the profession. So the final word from you, from the panel, and then we'll just turn to the recommendations briefly.
Okay, Alan, you know, what irritated nurses most, and it was a comment from an Italian nurse that said, you know, people are calling us, particularly governments are calling us, hear us now. We haven't changed. We're the same people. We're the same professionals that were there before COVID and that will be there after COVID. What we need is action, not to be called or to be told how wonderful we are. And we haven't seen action. I think when we're talking about what we're doing here today, which is great, it's about working together and it's about sharing, irrespective of what aspect of healthcare or what professional area we come from. If we have our agendas the same, it's about patient safety and we can all work together on that. I think there are a couple of things that I need to say. And one of the things, as you rightly said, mental health has been a huge issue in relation to nurses and the way that COVID has affected them. And as already has been said, it's not just about errors that have been done. It's about actually how this has affected them. Nurses have been with patients that are dying in isolation and without their family or friends. And I have talked to so many nurses that have been crying as a result of that, crying because they haven't been able to do enough for these people. And when you see nurses going home, wondering if they had done enough, and because they cannot leave that kind of reaction or that kind of emotion at work, that will have long-term effects on them. So I do worry about the mental health of nurses. I do think that what we have to do is we're preparing a strategy with WHO based on the state of the world's nursing for 2021-2025 in relation to the direction for nurses and midwives, which is about investment, it's about education, but it's also about using their full potential and about advanced practice. And that's cost effective, no matter which area of health and what country you're in. But there's also another area that I worry about. We weren't prepared for this pandemic. We have to have preparation for the next pandemic. And it's not just, it will come. It's not just a pandemic. You're talking about the natural and man-made disasters as well. And you're talking also about the fact that there are patients out there who have not had access to healthcare because we've concentrated on COVID, we've concentrated on obstetrics and emergency medicine. So that's a huge area that has to be tackled when all of this is over. The last thing that I would say is that the last economic recession made cuts, particularly to healthcare. It made cuts to the number of nurses in training. It made cuts to the this pay and salary and conditions they were getting. It made cuts to the number of nurses. In fact, they incentivized nurses to leave the profession. And that left us in a situation that we went in with a shortage of nurses. I am worried, as somebody said, we owe billions. What will happen now when they start to pay back the billions? I sincerely hope they have learned, governments have learned some lesson that they will not now cut healthcare, that they will look at healthcare differently, different models of healthcare. Yes, invest in different models, in better models and more efficient models, and use nurses to their full potential. But for heaven's sake, if they start cutting, and I can guarantee you, we will look at an economy that will be totally different because we won't have healthy people, so we won't have a healthy economy.
Well, Annette, up until the end of last year, I think it was Goldman Sachs estimated that the G20 countries spent $12 trillion on mitigating COVID-19. The figure for achieving, this was pre-COVID, the figure for achieving SDG 3 globally was less than $400 billion. And this is why, as you say, health spending has got to be seen as an investment, and it must be sustainable investment in global health security. So look, I want to thank the panel for their excellent introductions. I'd like to thank everyone who's been sending in messages. I've been watching them. There's a lot of interactivity from from people here during this particular week of Global Patient Safety and Healthcare Worker Awareness Week. I want to thank all the participants who've taken part. Please look at the report. One additional recommendation we're going to put in here is that healthcare professionals must be involved in the assessment of future pandemic preparedness and response. We'll be inviting the ICN to be part of our consideration on that, Annette, in the coming days. And please look at the recommendations. And what we want to do is really make these recommendations very concrete. And when we talk to the G20 and the G7 and the Commonwealth countries and the Francophonie, and we have the Global Health Summit on the 21st of May and the World Health Assembly on the 24th of May, let's make sure that these recommendations are acted upon, because we cannot, particularly when you look at healthcare workers, we are not going to be able to guarantee patient safety if we continue to see the hemorrhage of healthcare workers from our health system. So thank you all for participating. I'd like to thank His Royal Highness Prince Khaled for his participation today, Jeff Surges, of course, the great introduction by Dr. Tedros. Thank you for your participation, and let's continue the dialogue and see if we can try and make this a year where we bring about real change on these policy issues. So thank you for joining us. Bye-bye.
Thank you.